Hello friends, welcome again to your own YouTube channel Ask Your Gynecologist. I am Dr. Sonal Parihar and today's topic you must have already read. It is CTG, that is cardiotocography. Now this is a very intelligent topic and it is something that not many patients actually ask for, but some had actually requested. Some intelligent patients, some who are really curious to know what is going on in their inside the tummy and with the baby, they want to know what is CTG. So why do we call it cardiotocography? Cardio means heart. Toco means pressure and graphy means the graph. So what we do in this cardiotocography is we measure and we record your baby's heartbeat in relation with the pressure inside the uterus. That is tocography. Okay, so just like we do our ECG, we get an ECG recording that is only purely heart. In this cardiotocography, we are measuring the relationship between the baby's heartbeat and the pressure inside the uterus. So that is what we are recording. It is also known as non-stress test. Why non-stress test? Because normally cardiotocography CTG we advise in a patient who has reached around 36-38 weeks, because we know she's going to deliver very soon and we just need to check. We just want to check that her baby's heart is fine, the baby is happy inside. It is a reactive CTG. I'll tell you exactly what is reactive CTG. So we just need to measure all those parameters which I'm going to just tell you now, and that is why we do a CTG. And because she's not in pain, there is no pressure on the baby, so that is why we call it non-stress test. Okay, now this test can also be done during delivery and it is actually done in many patients. Like I have made it a protocol in my hospital. When the patient is in active labor, when I give her oxytocin or syntocinon for active contractions, at that time I need to know that the baby is tolerating those contractions well, that the heartbeat of the baby is not getting hampered by the pressure over the uterus. Okay, so that is the time when I put my patient on continuous CTG and she's in the labor room and I can see the changes in the heartbeat. Okay, many doctors do that. So that is one of the other kind of CTGs that we do, and another I would say indications for CTG. Now CTG, I should tell you, all the variations in the heartbeat of the baby is generally under the control of ANS, that is autonomic nervous system. Now there are two types of nervous systems, central nervous system and autonomic nervous system. So the autonomic nervous system of the baby normally matures after 32 weeks, that is in the 8th month. So before 32 weeks there is no point doing a CTG. Even if the baby is sick, CTG will not be very helpful. Okay, so after 32 weeks, if everything is normal, we do not do a CTG before 36-38 weeks, because that is the time when she is going to deliver, when she can have pains anytime, she can go into labor. That is the time when we need to check that the baby is fine. Okay, now what are the two things that we normally check? First is we will talk about the uterine contraction. Now the uterine contraction, when you are not in pain, when the patient is not in pain, then obviously the tocograph, which you can see in the graph, the lower line, you can see the uterine contractions are graphed in the units, right? It can be 40, it can be 60, it can be 0, it can go up to 100. So it basically records the baseline. That is when you are not in pain, then obviously that particular line will be like a straight line because there will be no activity in the uterus. If at all you are having pain, then it is going to measure what is the intensity of the pain, because then the graph will go up. It might go up to 100, it might go up to 40. So that depends upon the intensity of the contraction. It also tells us what time it is, till what time it is lasting, because the time it comes back to the baseline, that tells what was the exact duration of the contraction. And then another contraction comes and then we measure what was the time gap between the contractions. So we come to know three things: what is the frequency of contraction, what is the intensity of contraction, and what was the duration of the contraction. So these three things we measure in the TOCO, right? In the TOCO part of the CTG. Now coming to the fetal heart. Now in the baby's heart we measure four things. One is the baseline. Now you should know that the baby's heart is normally double as compared to an adult. When the baby is just about 6 weeks or 8 weeks, the baby's heart can be as high as 180 or even 200. Okay, when it matures, when it crosses 2 months, 3 months, then the heartbeat settles down between 110 to 160. There's a large gap. So 110 to 160 in a particular CTG graph, you will see there is always a green line in between, which shows that the heart has to stay in that green line, and that is a normal area. As soon as it goes below or above that, that is a red area. That means that is an alarming situation or an alerting situation. It is alerting the doctor that you have to do something. Okay, now the baby's heartbeat also depends upon the mother's heartbeat. So if the mother is like having tachycardia, she's having a heartbeat of say 100, 110, 120, then the baby's heart will also be affected. So it is a subjective finding. It is a very clinical thing that a doctor decides whether this particular heartbeat of the baby, if it is 160 or 170, is it normal or it's not normal. So we have to keep in mind many parameters, even the mother's heartbeat. Okay. Now the other thing that we measure, not just the baseline, the other thing that we measure is the variability. Now in adults, you must have seen, you see in movies as well, the ECG goes flat. That means that person is dead. In a child, in a fetus which is inside the uterus, the straight line doesn't mean that the baby is dead. It means that there is no variability. Now variability means up and down, up and down. That is how the heart of the baby goes, because it is under the control of autonomic nervous system. So the more the variability, the happier the baby is. The lower the variability, the less happier the baby is. So basically how we define variability, it has to go around 5 to 10 beats up and down as compared to the baseline, and that is called a variability. So good variability means the baby is happy, and if the variability is reduced, that increases our suspicion what is the problem. So we might sometimes ask the patient to go and have some breakfast, eat some sweet, because high glucose intake suddenly gives extra energy to the baby, and the baby's heart starts getting variable. Or you kind of just move the baby, you shuffle the baby so that the baby wakes up in case it is sleeping. So these are certain things that we do in the OPD in case the variability is low. The other thing that we measure is acceleration. Just like we drive a car, we put on the accelerator so the car speeds up. Similarly, acceleration means there is a speed up in the heartbeat. So how do we define it? What is the difference between acceleration and variability? Well, in acceleration, the heartbeat has to increase at least 15 beats above the baseline. At least 15 beats above, and it has to take at least 15 seconds to come back. It should not be like this. That is a spike. Okay, that might be an error. So an increase in heartbeat of 15 beats per minute above the baseline, and it takes 15 seconds to come down, that is an acceleration, and the more the accelerations, the happier the baby is. What is reactive CTG? Now I tell you, there should be at least 2 accelerations, as I defined, 15 beats for 15 seconds in a 20-minute graph, whether the baby moves or not. Now there is another button that we normally give to the patient. Normally when she lies down, there will be 2 belts. She'll be like having 2 probes, one on the top of the uterus to measure the TOCO, and one around the heart wherever the fetal heart is. So these are the 2 probes that we have. Another wire attached with the probe, we give it to the patient. The patients who have had a CTG, you will probably understand what is that button is. You just have to press that button in the 20-25 minutes graph that you are made to lie down, and you have to press it whenever you feel the baby is moving inside. Why we do that? Because as soon as she presses it, there is a mark on the graph which comes up, and it tells us this was the particular time when the baby moved. At that time when the baby moves, the heartbeat should normally accelerate. Just like when we walk, when we jog, our heartbeat goes up. Similarly, the fetal heart, the baby's heart, has to be reactive to any stimulus. Like if the baby is moving, the heartbeat should go up. So our reactive CTG is when there are 2 accelerations in that 20 minutes graph, whether the baby moves or not, immaterial. The CTG graph has to show that an acceleration, even if the baby doesn't move, because sometimes the babies might not move in 20 minutes. Sometimes the patient may not be able to perceive that. Sometimes she may not be pressing the button properly. Sometimes even if she presses, the mark may not come. There may be a technical error. So we just basically measure the acceleration. If there are 2 accelerations in a 20-minute graph, we are happy. Okay. The 4th thing that we measure is a deceleration. Just like acceleration, it is just the opposite of acceleration. The heartbeat has to go down 15 beats below the baseline, and it has to take at least 15 seconds to come back. That is a deceleration. Now there are 2 types of decelerations: early and late. Early deceleration means it is coinciding with the contraction. Whenever the uterus is contracting, the spike is going up. Similarly, the heart of the baby is going down. So they are kind of mirror image of each other. This is because why this happens: when the uterus is contracting, the baby's head is getting compressed. So because of this compression, the autonomic nervous system sends a stimulus which is called vagal stimulus, which decreases the heartbeat. But this is quite normal because it will happen whenever there is some pressure over the uterus. The baby's heartbeat will go down, but it should automatically go up. As soon as the contraction is coming down, the heartbeat should go up to normal. So that is an early deceleration, and it is nothing to worry about. Now the one which we need to take action upon, or we need to be worried about, is late deceleration. Late, as the name indicates, it goes down and it does not come back as the contraction is coming back. Okay, so that means it is staying and it is taking longer to come back. Even if the contraction is over, the uterus is relaxed, the baby's brain is not getting enough oxygen or it is ischemic. Because of that, the heart is not responding, and that is where when we take an action, we need to do other tests, we need to do some, maybe fetal blood sampling or some other tests, or we need to take an action that yes, the baby needs delivery. Okay, now there is another variant of this late deceleration, which is prolonged deceleration. Prolonged deceleration is when the heartbeat does not come back to normal for more than 15 seconds. Okay, so it is taking more than 15-20 seconds to come back to baseline. That is an alarming situation. This is when the doctors will ring the bell that it is an alarming situation. Either we put a forceps or a ventouse to deliver the baby, because the baby has to come out. If it is a fully dilated cervix, then the forceps or ventouse, or if it is not dilated, then it has to be a cesarean. So let your doctor decide, and this is an alarming situation which you should understand. Okay, so guys, this is all for today. This is all you need to know about CTG, and CTG is generally not decisive for delivery. It is just a supportive thing. We use CTG to be rest assured that everything is fine. If it is not, if it is suspicious or if it is pathological, that means we need to do some other tests, or we need to just hasten your delivery. Okay, now the two variants that I just talked about is suspicious and pathological. Suspicious means one out of these parameters which I discussed is abnormal. Either the baseline is abnormal, variability is low, acceleration is not there, or deceleration is abnormal. Okay, if there are two parameters together, then that becomes a pathological CTG and action has to be taken. And I've told you what action we take. We either do a fetal blood sampling, or we immediately rush you to the OT for cesarean, or we just immediately put a forceps and get the baby out. Okay, so this is all for today. I hope you liked the video. If you liked it, please click the like button. Please subscribe to the channel, because I'm going live every day to answer your questions. So unless you subscribe, you will not get a notification. I cannot tell you the exact time when I go live. So if you click on the subscription button, then you will get a notification that Dr. Sonal Parihar is live. I'm answering all your questions live every day. You can also inbox me on my Facebook pages or Instagram, because sometimes the questions on the YouTube are hidden. I am not able to see all the questions, but I'm trying to answer every question, each and every question every day. It's better to ask medical questions on the YouTube channel. Do download the DocWise app. If you see the introductory video, the 15 seconds video, which comes before my video actually starts, it has given you the DocWise app and the pin as well. So DocWise app, if you just put on the Play Store in the mobile, if you just click on the pink one, that is for the patients, and download it, and then it will ask you for the doctor's pin. You put my pin, this is my pin, and then you can easily talk to me. You can send me a voice message, you can send your reports to me. If you want to really talk to me, you can just send a message, please call, I will call you. And this is a wonderful app. It's just 200 rupees for 2 days, and it is very easy. So many patients have connected with me. Even patients abroad, out of India, are trying to connect through this. So it's a very easy thing. If you're not able to get through this app because you're living abroad, out of India, you can always call my secretary. These are some phone numbers that I've given. The hospital landline number. It's better to call my secretary. She will tell you, she will guide you how to do it. Okay, so till then, take care. I'll be back again with a new video. Bye bye.